Good afternoon. I'd like to thank the European School of Urology and the EAU section of Oncological Urology for organizing this webinar on adverse events and toxicity management in the treatment of metastatic prostate cancer patients from an MDT perspective. This UROwebinar aims to educate healthcare professionals on managing adverse events and toxicity in metastatic prostate cancer patients. We will focus on understanding the commonly faced adverse events and their early detection associated with systemic therapies in metastatic prostate cancer, improving toxicity management. At the end of the webinar, there will be an interactive questions and answers session to facilitate knowledge sharing. With this, I'd like to introduce Professor Alvaro Pinto, a medical oncologist from La Paz Hospital in Madrid, Spain, who will help us in understanding adverse events in metastatic prostate cancer treatment and will describe their classification, prognosis, impact on quality of life of our patients. Thank you.
Thank you, Giorgio, and thank you to all the organizers for the kind invitation. This is like kind of an introductory talk, very brief talk, just to set the scene, right? Because when you try to choose any given therapy for individual patient, you focus on efficacy, you focus on adverse events, you try to elucidate if this drug will give you more dizziness, more heart toxicity, more hematological toxicity. But at the end of the day, I think that we should go beyond that, and not ticking adverse event by adverse event, but seeing like more in a global way how the treatments or the decisions that we make, in this case, in patients with metastatic prostate carcinoma, influence quality of life globally, not just by having a 5% more fatigue or 5% less neutropenia. I think that it's much more complicated than that. So these are my disclosures. Just as a brief introduction, I'm sure you're all aware that metastatic prostate cancer is a non-curable disease. So when we have different treatment options with high efficacy and possibility of long life expectancy, we should balance the survival benefit that we see in the trials and in real-world studies with the toxicity and the potential impact in quality of life. It's not, we are not trying to cure the patient. Hopefully, we will be able in the future, but now we are trying to extend the life as much as possible, and the patients will live long, but also live better while having the metastatic prostate cancer. So how to properly address and manage these side effects would be the first question, but also how to both measure, which is a tricky question, the quality of life, and also to maintain or ideally improve the quality of life of our patients while on treatment. And I also would like to just a brief sentence. I think that it's much beyond that, the scope of this webinar, but when, as I say there, almost everything improves survival, we have a lot of drugs that improve survival. When should we think about stopping therapy? The balance between the expected efficacy and the expected also toxicity is also important to say when do we have to think about stopping or withdrawing any systemic therapy. I mean, this is a classical three-way to see any approach in any given patient for systemic therapy in this case. I mean, if you manage toxicity well, you will achieve the greatest benefit of the drug. I mean, you have to you choose one drug, use it well, because if not, you won't get the most of the benefit. And this is influenced, of course, by the patient, by comorbidities and medication, and also patient preference, which is something really important to take into account, to take into consideration when we have different options in a particular setting, in this case, in metastatic prostate cancer. Also the tumor, response to previous therapies, aggressiveness, extension of the disease, but also the treatment, the incidence and the severity of the adverse events that we may expect when we initiate any given therapy, and also the possibility of the proactive management. I mean, can we prevent any toxicity to become a serious adverse event, or is something that is unexpected and there's nothing we can do to avoid that? So what is an adverse event? And I think that we are also very familiar with these definitions, but if you go to the definition, the FDA and the EMA definitions are very similar. I mean, it's almost anything. Any untoward medical occurrence associated with the use of a drug in humans, whether or not, in this case for systemic therapy, considered drug-related. That's the main reason that we see adverse events in placebo arms of clinical trials. then you may, as an investigator or as a researcher, decide if this is related, possibly related, completely unrelated to the drug, to the experimental treatment, but that's an adverse event. So that's why we see adverse events also, as I say, in placebo arms or trials. And what is a serious adverse event? And in this case, the definition is exactly the same. Is something, maybe drug-related or not, that results in death or is life-threatening, requires hospitalization or prolongation of hospitalizations, etc. So we can classify these adverse events by different ways, and it will also depend of any patient on the drug that the patient is receiving. We can base the toxicity, as I say, they're organ-based, for example, cardiac toxicity, digestive toxicity, hematologic, skin, etc. It's just some few examples. But we have also seen more and more reviews and guidelines, or whatever, treatment-based. I mean, human immunotherapy-related toxicity, chemotherapy-related toxicity, hormone therapy, targeted therapy, etc. And the classification that we are mostly used in clinical trials based not on organ or treatment, but also in severity. The grade 1, grade 2, grade 3, grade 4, and grade 5, sorry, which is mainly death. But for this is just an example of the CTCAE booklet that is a guidance to report toxicities inside clinical trials, and this is anemia, and you can see that this is very, I would say, easy to grade because it's numeric. For other toxicities that we will see in a couple of minutes, it may be harder to differentiate between a grade 1, grade 2, but this is how we all are used to see the toxicities reflected in clinical trials. But if adverse events are so important and are crucial to make our decisions, are we good as clinicians at identifying AEs? And this is, I mean, there are a lot of examples. This is a classical study for 20 years ago with chemotherapy. And this, I mean, sets the scene pretty clear. We are not good at identifying AEs. This is a study in patients with chemotherapy that compared the symptoms reflected by the clinician in the clinical history and the symptoms reflected by the patient in quality of life questionnaires. And we see that, for example, even for dyspnea, which is, I mean, this is a severe symptom, 77% of the cases, the physician missed to report dyspnea. Didn't ask the patient, didn't consider to be something worthy to ask for. For nausea and vomiting, for example, the difference is not that big, but still there is. So we are not good at identifying or at asking to individual patients what are their main symptoms or their main adverse events. So we're not good at identifying AEs, and we should be aware of this. We may be too in a hurry, a lot of patients, a busy clinic, and whatsoever. The patient may also try to diminish the importance of adverse events because they may be worried to, if I say I'm too sick, they will lower the dose, they will stop treatment, and I don't want that because I want to make it as good as possible. But if adverse events by themselves, tick by tick, item by item, is not enough, what is quality of life? This is also a classical definition, not only for oncology, but for social sciences, right? So you can see that there, but the heart of the definition is that's multidimensional. It's physical, it's emotional, it's social well-being. So quality of life is not just a summary of adverse events alone. It's influenced by the symptoms, the baseline symptoms that the patient has, and how they improve or not under therapy. Also, the patient-reported outcomes that we will see in a while, the main difference, we try to group everything in the same box, but it's not exactly the same. And also what I would like to call the factor X, something else. Not every patient gives the same importance to the same symptoms or have the same influence on how they perceive quality of life. So it's much more complicated than just grouping adverse events and trying to see what comes in a questionnaire, for example. Quality of life is not the same as patient-reported outcomes, and it's not the same as health-related quality of life. Quality of life, and this is also a classical slide by one of the biggest experts in the world with quality of life in systemic treatment in cancer, Professor David Sella. Quality of life evaluates all aspects of life, not only health-related, drug-related, toxicity-related. Health-related quality of life evaluates the impact of illness or treatment on these physical, emotional, and social aspects of quality of life. And PROs, as the name says, is anything reported by a patient. You have all these trials, recapping PROs by tablets, by paper questionnaires whatsoever, and the patient can report anything, but that not necessarily is the same as quality of life. So, and I would divide the scientific community, and we may speak about that later if you wish, amongst quality of life believers, because we know that quality of life is important, and we have more and more evidence that survival is probably correlated with health-related quality of life improvement and patient-reported outcomes. It also gives a very important role to the patient. It empowers the patient because it's part of the clinical process and the decision-making process, because it's like the input of the patient is better reflected with these quality of life questionnaires. And also because we are not only measuring the percentage of nausea, neutropenia, or so on, because this is much more a multidimensional measurement of treatment impact. But there are also quality of life skeptics, because we all know that even though the clinical trials have very good data, and we all like to see this quality of life improvements, we know that also it's hard to implement in everyday practice. Long questionnaires, hard to fill by the patient. We don't know which scale, which questionnaire, when to measure, at the beginning, every 12 weeks, every 6 months, and what is significant, an increase or a decrease of 2.5 points in a QLQ-C30 is clinically significant or not. And that's and also the lack of reliability. There are many confusion factors that may affect an individual patient when they are filling these questionnaires, if he has pain or not, if he's accompanied by family or caregivers or not, if the caregiver is the one who fills the questionnaire, which is, I would say, really common in Spain, and I'm sure that also in other countries, that it's not the patient, the one who fills the questionnaire, which is the caregiver or the relative. So I think that ideally it's a very good tool, but in real life, I think it's still a long way to go. It's hard to implement and to translate into decision-making based on quality of life evolution throughout the treatment. But if we think that the patients have a role, let's see just a couple of samples before we finish this introductory talk. What do our patients say? Because if we give the voice to the patient, and of course, there are a lot of studies in a lot of tumors. I just focused in a couple of studies for prostate cancer. This case is for metastatic hormone-sensitive prostate cancer. It's a discrete choice experiment, as you see in the title, in 3 European countries. And in the metastatic patients ranked effectiveness as the most important item to value above pain control, which is the second, and then other side effects like nausea, fatigue, infections, and route or mode of administration, IV versus oral. So between these 6 items, patients give the least of the importance to the mode of administration and the most important to effectiveness and pain control. Another study, in this case in mCRPC, metastatic castration-resistant prostate cancer, that was presented a couple of years ago at ASCO GU. In one side, they asked which were the most frequently reported symptoms by these patients, which are mainly pain and urinary problems, and then fatigue. But then they ask which would be the most important treatment benefits that they would like to achieve when they start treatment. And the first one is quality of life, then delayed time to disease progression, and then overall time alive and reduced pain. So first of all, quality of life as a concept is important for patients. And even though we may think that time to progression is not as important as overall survival, patients also feel like delaying time to disease progression can be as important as overall time alive. And the last example published last year, I think it's also very, very interesting, and we may also discuss this later. If we get the similar items, they would be more or less in the same order: overall survival, percentage of patients who need radiation, which is like saying pain or not well-controlled pain, as the main symptom. That's the main topics that would be of the highest importance. But then they do like a kind of experiment, like a kind of question, saying that how many months in overall survival would you be able to change to obtain a benefit, for example, in reducing the 50 to 20% the chance of needing radiation for bone pain, which is the item that the patients would be willing to trade, to say that way, 6 months of survival if they are lowering the chance of needing radiation for badly controlled pain. So Overall survival is important, but symptom control is also important. And another example for not having nausea, like 4 or 5 months from severe nausea to no nausea. So, I mean, overall survival is important, but it's, as I said, it's a trade-off between toxicity and efficacy. Patients are not willing to say, give me everything you have, and I don't care about side effects. It's mostly the opposite. And one last thing that we should think about before finishing. For patients to make decisions, they have to be well informed of the situation they are in, at least if they want to know it. Of course, patients may not want to know the exact prognosis, but if patient wants to know, if patients ask for what to expect in metastatic prostate cancer, they should know it. And I would say that unluckily, that's not the situation. This is also a study for metastatic prostate cancer. These are two small graphs, like the reported likelihood of prolonged life expectancy. You can see that very likely, somewhat likely, of symptom relief, don't know, but I think that we should improve in this graph, because patients with metastatic prostate cancer, almost 1 out of 3, almost 30% of patients, they feel like there's a likelihood of cure from systemic therapy, with more than 20% saying that it's very likely or somewhat likely to get cured from the systemic therapy they are receiving. If the patient is not well informed, they can also cannot make informed decisions. So I think that it's also important to, when the patient is offered a treatment, they should be well informed what to expect, what's the situation they're in, of course, the adverse event profile, but also the what to expect and the likelihood of getting any benefit from the treatment we are starting. So just to conclude, as I hope to have convinced you, adverse event profile and impacting quality of life should be key factors when deciding which treatment should be prescribed to an individual patient, not just efficacy. I think there's much more to discuss about. We should take enough time to inform both patient and caregiver about the goal of the treatment and also the expected toxicity. Don't take for granted what the patient prefers, because we may, I mean, there are a lot of, every person, every individual is different, and some patients may want effectiveness above everything, and some patients may want quality of life above everything. And as I said, proper adverse event management contributes to achieve the optimal efficacy of the chosen therapy. Thank you. Thank you for your attention.
Thank you, Alvaro, for this great presentation. And I think we will leave all the questions for the end of our talks. I'd like to invite all participants to use the chat to send their questions, and we will answer them through the chat, or we will answer them at the end of our presentations. With this, I will share my screen, and we will discuss about how can we prevent adverse events. In particular, we will focus on bone health and other measures to improve the quality of life of our metastatic prostate cancer patients receiving systemic therapies. These are my conflicts of interest. And as you can see, this is a list coming from a very nice systematic review of the literature published on European Urology 9 years ago, and which is still contemporary, and which is listing actually all the most common ADT-related side effects in metastatic prostate cancer. And the first one is decreased in bone mineral density. We have metabolic changes. We have decreased libido and sexual function. And we have obviously anemia, fatigue, but also diabetes and cardiovascular events, which are all very relevant for our patients. And as Alvaro was saying, we are discussing about treating the patient and not just the cancer. We should balance the therapeutic benefits and potential treatment-related adverse events. Patient-centered communication is crucial, and healthcare professionals should closely and frequently monitor patient treatment responses. We should focus on understand symptoms onset and their exacerbation, and we should timely provide patients with measures that can relieve their quality of life. In this context, patients should be encouraged to participate in exercise programs, and health information and support groups to provide a support in order to improve the quality of life while they're receiving these systemic therapies. This is the agenda for this talk, and we will firstly focus on the bone health in metastatic prostate cancer. When we have a patient in front of us and this patient needs, for example, androgen deprivation, is an hormone-naive prostate cancer patient, well, his risk of having osteoporosis is already up to 35%. So we have approximately 1 patient out of 3 coming to our office with an hormone-sensitive metastatic prostate cancer with osteoporosis. And this goes as high as 80% of patients after 10 years of treatment. The annual rate in a healthy man of bone loss is between 0.5 and 1%, but when we look at patients who started their first year of ADT with metastatic disease, this goes up to 8% in the lumbar spine and 7% in the hip. And this is related to the androgen deprivation effects on bone health. Testosterone deficiency promotes the activation of RANKL production from osteoblasts, and this leads to the differentiation and the function of osteoblasts. The final consequence is increased bone resorption and decreased bone mineral density. We have also issues related to estrogen deficiency and to neuroendocrine effects related to low circulating testosterone levels. This applies also to novel ARPs, and this is a nicely written systematic review of the literature published in European Urology Open Science, and it is still in press. And as you can see, the authors were able to assess the risk of any grade fracture and grade 3 or higher fracture associated with the use of novel ARPs, and they were able to stratify patients according to the disease stage and the agent. And in virtually all settings, the use of ARPs was associated with an increased risk of fractures and falls. And this was consistent with all type of drugs. There are some differences, minor differences, when we look at, for example, abiraterone and apalutamide or enzalutamide. They are associated with an increased risk of grade 3 or higher fractures, while the risk of any grade fracture is similar across all the treatment spectrum. We should focus on how to prevent these non-metastatic related skeletal events. And how can we do it? Well, first of all, we need a precise evaluation of the bone mineral density before starting long-term ADT. And patients should receive a dual energy X-ray absorptiometry. And based on this, we will have a score, and the low BMD score indicates a high risk of non-metastatic fracture, and we should firstly investigate the causes, and secondly, we should start with therapies aimed at preventing bone events. These are the risk factors associated with non-metastatic bone fractures in prostate cancer patients, and you can see that increasing age, an history of falls and other chronic medical conditions, alcohol consumption, and the use of glucocorticoids, smoking, an history of previous fractures, and a BMI of 19 or less, they are all considered as risk factors for non-metastatic bone fractures in this setting. As we were saying, imaging can help us, and based on our guidelines, on the EAU guidelines on prostate cancer, we should offer men starting long-term ADT a dual emission X-ray absorptiometry to assess the bone mineral density, and these should be repeated over time. This is how we should interpret the results of this test, and the distribution of the bone mineral content in young healthy adults is typically normally distributed, and you can see that the results are expressed in the relation of a reference population and in standard deviation units. We can consider patients with osteoporosis when the T-score is less or equal to 2.5 standard deviations. And when it is below 1, between -1 and -2.5, where we are in a situation of osteopenia. What is somehow scaring, talking from an MDT perspective and talking from healthcare professionals dealing with prostate cancer patients, is that this test is used in less than 10% of patients with prostate cancer receiving ADT. And these are results coming from the US. You can see that basically over time, the use of DEXA scanning increased from 7 to 8% more or less, but still being single, non-Hispanic Black, was living in small urban areas and with lower educational levels. These are risk factors for not receiving this type of assessment before starting ADT. Receiving a scanning was associated with a decreased risk of fractures, and what is more important, is that patients who experience fracture are actually the one less likely to survive at long-term follow-up. So we are talking mainly to urologists here, and even if we are not directly involved in many patients in the management of our patients starting novel systemic therapies in many countries, at the same time we should be the ones dealing with these patients and the ones coordinating their management and the ones who are able to recommend the correct testing to our patients before starting ADT in order to prevent non-metastatic events, fractures, and bone loss. There are other tests that can be used to prevent the risk of skeletal complications. This is an example, and it is still based on risk factors, and it gives us a 10-year probability of major osteoporotic fractures or hip fracture. Of note, this test, the FRAX-derived fracture probability, has not been specifically developed for patients receiving ADT, and it is widely used, but still we don't know if it is 100% applicable to this patient population. Finally, we should also consider serum blood tests, such as serum calcium and vitamin D, and we should be able to provide adequate calcium and vitamin D3 intake when we see that patients are at risk of osteoporosis and of fractures. How can we prevent non-metastatic skeletal-related events? Well, first of all, anti-resorptive therapy and bone remodeling agents are recommended to reduce the risk of fragility fractures in patients at high risk due to diminished bone mineral density while on ADT for hormone-naive prostate cancer. And we can use both bisphosphonates and denosumab. They prevent bone loss, and these agents are also indicated at higher doses to prevent complications from bone metastasis, but this is true only for patients with metastatic castration-resistant prostate cancer and bone metastasis. This is a pivotal study published in 2009 in the New England Journal of Medicine, and this study was able to demonstrate that the administration of denosumab 60 milligrams subcutaneously every 6 months was associated with an increased bone mineral density in patients receiving ADT, and it was also associated with a decreased incidence of new vertebral fractures at 3-year follow-up. This is a randomized, double-blind, multi-center controlled study. There are basically few studies and limited evidence comparing denosumab and bisphosphonates for the prevention of non-metastatic bone events. And this is an example, a study published a few years ago. And in this study, the authors were able to show that the bone mineral density changes at the lumbar spine at 2-year follow-up were lower, let's say, with denosumab compared with alendronate, and even if it was not statistically significant, there were fewer new vertebral fractures in patients treated with denosumab compared to alendronate. So we should consider bone remodeling agents and anti-resorptive therapy in men on ADT for more than 6 months who are at risk of experiencing new fractures and at risk of osteoporosis. And we've seen which instruments should be used to assess this risk. We should also consider referring these patients to a bone specialist in complex cases, and we should monitor and prevent the side effects associated with the use of these therapies, which are mainly related to the osteonecrosis of the jaw and hypocalcemia. Be careful when discontinuing treatment because we can have a rebound increased bone resorption. And this is a slide showing you the recommendation in terms of non-pharmacologic preventive measures, the risk assessment, and again, the use of bone anti-resorptive therapy in this setting. Finally, when talking about prostate cancer patients with metastatic disease undergoing systemic therapies, we should focus on other measures to prevent detrimental quality of life. First of all, the psychological distress. We know that patients receiving systemic therapies for metastatic prostate cancer have a 31% higher risk of depression and of dementia compared to their counterparts receiving placebo. And we should be able to identify these patients based on risk factors such as older age, marital status, comorbidities, and previous history of depression, and to refer these patients to a specialist. We should also acknowledge that these patients are at risk of cardiovascular morbidity, and this applies both for patients receiving ADT and ADT plus novel ARPs. And there are population-based studies and real-life data which propose an impact of GnRH agonists and novel ARPs on the risk of cardiovascular disease and sudden cardiac death in the setting of prostate cancer patients. And this is related to the cardioprotective effect of testosterone. How can we prevent it? Well, exercise and training can prevent the cardiovascular events in metastatic prostate cancer, and the supervised exercise therapy is superior to no exercise therapy in providing our patients clinically relevant improvements in disease-specific quality of life and working performance. Finally, we should be aware that our patients will be somehow bothered by the loss of sexual function compared to patients not on ADT, and we should provide our patients a proper sexual counseling, and we should focus also on the partners. Strategies to mitigate ADT-related side effects in terms of sexual function are, for example, the use of intermittent ADT, and this is an example of an algorithm proposed for selected patients in order to provide an adequate quality of life and an adequate sexual function. And these are the guidance. Again, they recommend the assessment of the bone health before starting ADT, and they recommend providing our patients all supportive measures to prevent side effects and to deal with the side effects related to the use of systemic therapies in the metastatic prostate cancer setting. Before starting long-term ADT, consider performing a dual emission X-ray absorptiometry scanning to assess the bone mineral density, and we should consider anti-resorptive therapy to men on long-term ADT at risk of osteoporosis, with osteoporosis, or with osteopenia, and additional risk factors. We can use the FRAX score or other scores to assess the risk of fractures in this specific patient population. To conclude, ADT and systemic therapies nowadays represent the cornerstone for the treatment of metastatic prostate cancer, but they have a significant risk of side effects impacting bone health, metabolic function, cardiovascular health, and sexual function. We should monitor our patient. We should assess the baseline risk of bone side effects, for example, of cardiovascular side effects and cardiovascular events. A multidisciplinary approach is necessary in this setting and should include lifestyle changes, psychological support, patient-centered communication. And obviously, supportive care strategies are key to reduce the burden on patients and their partners of systemic therapies and to improve quality of life in metastatic prostate cancer. Thanks for your attention. With this, I think we can move to the next presentation, Alvaro.
Yeah,
on
thank you, Giorgio.
toxicity management strategies.
Okay, thank you. Now, in the last part of the webinar, we are reviewing like the taxanes and PARP inhibitors, maybe some of the one classic systemic therapy, which is chemo, and also another systemic therapy that may be the entrance door to precision therapy in prostate cancer, which are the PARP inhibitors, but focusing not on the different controversies on when to use it and the sequence and when to test and whatsoever, but just focusing on the toxicity management strategies for these two classes of drugs. These are my conflict of interest. Again, they haven't changed much since the last presentation. So this is a summary of the different stages of the disease that the patient may go through while on their journeys in prostate cancer. And the thing is that it's complicated to choose a therapy in a patient because in the last less than 20 years, 10 to 15 years mainly, all of these combinations improve overall survival in these settings. So, and what you use in a previous setting also influences what you give in next stages of the disease. But all of this improves overall survival. And that's why I said in the first talk about the general scope of adverse event management that almost everything improves survival. So when to stop sequencing, when to stop giving treatment, when to stop starting another line of systemic therapy. So I think it's a question with no answer yet, but it's a very tricky question. This is the same slide before, so I will go quickly. The patient, the tumor, and the treatment are key factors to be considered. And in this case, for taxanes and PARP inhibitors, we're focusing on the treatment and the toxicity that we may expect with these two classes of drugs. Let's begin with the oldest one, with the old-fashioned docetaxel, right? This is the study, the TAX 327, published in 2004. Just as a reminder, this was the first study of any systemic therapy in what was called hormone refractory prostate cancer. Now we all call this setting of disease castration-resistant prostate cancer. And as I said, docetaxel every 3 weeks was the first drug that demonstrated to improve overall survival. And this is the toxicity, the tables that we oncologists like so much to see, but that I always try to summarize and not just get in the numbers. So what to expect in a patient with mCRPC, in this case, when you initiate docetaxel. One of the main concerns when we initiate chemo is the hematologic toxicity. Docetaxel has mainly white blood cells toxicity. I mean, the anemia and thrombopenia are not so frequent and less as a severe adverse event. We see that the grade 3-4 neutropenia is 1 out of 3, 32%, but the rate of febrile neutropenia, which is a severe complication that we should try to avoid, is only 3%. But we may expect some grade of neutropenia in our patients. Also, the digestive toxicity, which is mainly diarrhea and mucositis, stomatitis, is all-grade diarrhea, 32%, and all-grade stomatitis, 20% of patients, and other toxicities that we should tell patient and the caregiver that are relatively common with this drug is alopecia. Nail changes. I mean, the nails are frail. There may be infections in the skin tissue, in the soft tissue surrounding nails. Of course, this may not be considered a serious toxicity, but it's a really painful toxicity. I mean, it's really bothering to not be able to manipulate things with your hands because your nails hurt so much. Also, fatigue is common, but in severe fatigue, severe asthenia is only in 5% of patients, and also the sensory neuropathy in 30% of patients. But once again, the severe neuropathy is very, very strange, less than 1-2% with this drug, with docetaxel. For docetaxel, apart from the general recommendations of taking your time to explain the patient, first of all, what to expect, but secondly, and almost as important as that, when to come back earlier than expected, not to wait until the next appointment in 2 weeks or in 3 weeks. If the patient has the classic definition from febrile neutropenia, more than 38.3 degrees for more than 24 hours, they have to come back to hospital earlier than expected because the risk of febrile neutropenia is high. Also, the patient should be advised to have a proper oral hygiene to avoid mucositis as much as possible, and symptomatic treatment of diarrhea with loperamide in case it's needed. Not every patient has a diarrhea requiring supportive therapy, but the patient has to have loperamide or any other anti-diarrhea drug at home in case they need it. Also, I mean, there's not a lot we can do to prevent neuropathy and nail changes, but of course, the patient has to be aware that this may happen. And for the main concerns for neutropenia, both dose adjustments and prophylaxis with GCSF, with colony-stimulating factors, can be considered in frail patients or in patients that have already had this toxicity in previous cycles. I mean, this has been proven. This is not like the patient feels bad, has a toxicity, I lower the dose, I don't know, 15%. No, I mean, this has been proven in several trials. This is the most important one, I would say. This was published by the Finnish group in 2013. It was a non-inferiority trial comparing the standard dose of 3-weekly docetaxel at 75 milligrams per meter square, compared with a 2-weekly dosing of 50 milligrams per meter square. As I say, the goal was to prove that the adapted dose, the 2-weekly, was non-inferior and had less toxicity. In fact, the trend is that it was even superior in survival, and there was less toxicity, mainly neuropathy, diarrhea, stomatitis, and neutropenia. We also published our experience last year. We had a review of our patients treated with 2-weekly or 3-weekly dosing of docetaxel. This, of course, has a bias because if you decided of an individual patient to start with the adapted dose, these patients were more frail, comorbidities, older. But even though having the worst patients, I would say, in the group of 2-weekly 50 milligrams per meter square, we also confirmed that the survival was similar, where there were no significant differences, and the toxicity profile favored the 2-weekly scheme. So in a patient, either if it's too frail, if you have a geriatric comprehensive assessment saying that the patient is not fit enough for standard dosing, you may begin with the adapted schedule, or in a patient that has begun already with the standard dose and had toxicity, mostly hematological toxicity, you may switch to an adapted schedule of chemotherapy without having any fear of losing efficacy because of this dose adjustment. The other taxane that is widely used in clinical practice is cabazitaxel. This was developed to overcome resistance to docetaxel. So these patients treated in the TROPIC trial, which was the pivotal trial published in 2010, were patients that had already received docetaxel. And in this case, the most prominent toxicity by far is neutropenia. In this case, for this trial, the grade 3 for neutropenia was as high as 82%. The rate of febrile neutropenia was not as high compared, but it was still around 10%. But the less, the rest of the toxicities that you may find with docetaxel, like digestive, neuropathy, and others that we have spoken a couple of minutes ago, are less common with cabazitaxel. So the main concern with cabazitaxel is the risk of severe hematological toxicity. Asthenia, nausea, diarrhea, as I said, are less common with cabazitaxel compared with docetaxel. So when you start the patient with cabazitaxel, you should mainly watch out for neutropenia. Of course, anything can happen in an individual patient, but the risk is higher for severe neutropenia in these patients. Cabazitaxel was compared with docetaxel in first-line chemo, and it was not superior, not in efficacy, and not in a significant difference in toxicity. So cabazitaxel is still restricted to patients that has already progressed to docetaxel, but we have also a phase 3 trial comparing the dose, the standard dose for the tropic trial, which is 25 milligrams per meter square, to a reduced dose to see if, once again, a non-inferiority trial to see if efficacy was the same, but toxicity profile was improved. And that was the case. So now the standard dosing for most of patients, I would say 99% of patients, should be the reduced dose of 20 milligrams per meter square, because you see that the overall survival is exactly the same. And once again, a lot of numbers. To summarize, with the standard dose, you have less grade 3 for neutropenia, less febrile neutropenia from 10 to 2%, and globally less grade 3 for all-cause adverse events. So you should start as a standard practice with the now reduced dose. No one speaks about standard dosing for the 25 milligrams, which was the dose used in the pivotal trial of cabazitaxel. And before we finish, just moving on to a more controversial and more, there are a lot of talks about PARP inhibitors, when to use it, when to test, what to test, monotherapy combination. But as I say, we are just focusing on toxicity. This is the rationale of using PARP inhibitors, that you are also aware that if the tumor cells of a patient that may be somatic of germline, but at the end of the day has one of the DNA repair systems damaged, we target the other DNA repair system with PARP inhibitor, so the tumor cell is induced to cell death, because there's no way they can repair the accumulating damage in the DNA. We have had so far 2 classes of trials with PARP inhibitors: the monotherapy, the oldest one, and the one that started all this field of research was the PROFOUND trial with olaparib. But we also had trials in combination with novel hormone therapy. So one example, there are a lot of trials. It's not the scope of the talk to review all the PARP inhibitor development in prostate cancer. This is one example, the TALAPRO trial with enzalutamide and talazoparib, and you see here once again the toxicity tables of the articles. What you can expect with PARP inhibitors? First of all, hematological toxicity. This is a systematic review of all the drugs, all the trials, and for every hematological toxicity, anemia, neutropenia, thrombopenia, and grade 3 for each of these, all PARP inhibitors increase the risk of having hematological toxicity, and in all series, as you see, not only in the white blood cells, but also in red blood cells and platelets. What you can expect, once again, is a very, I would say, a high rate of anemia, which almost 1 out of 3 patients having a grade 3 for anemia that is requiring blood cell transfusions. Neutropenia is not as high as with chemotherapy, and there's almost no cases of febrile neutropenia, and thrombopenia amongst these 3 toxicities is the less common one. But up to 30 to 40% of patients may require blood transfusion while on PARP inhibitors. As I said, neutropenia is not usually a problem. It's managed with dose adjustments, and the rate of febrile neutropenia, which is the complication, as I said before, that you should avoid, is less than 0.5%. And the thrombopenia is manageable with those adjustments, and the risk of bleeding and other complications with low platelets counts is anecdotal, less than 0.5%. And one thing that we may begin to see more and more, if we begin also to use these drugs in earlier stages of the disease, and for long-term treatments, not for 6, 8, 12 months, which is the time on treatment for mCRPC, is that approximately 1% of patients under PARP inhibitors develop myelodysplastic syndromes and acute leukemias. That's a very serious complication, as you may expect. And we don't know if this incidence will get higher, as I said, when we use this in earlier phases and with longer treatment exposure. The non-hematological toxicity, the data is lower for hematological toxicity, and as you see, the grade 3-4 toxicities, that nausea, fatigue, and decreased appetite, which are the most common, are, I would say, anecdotal, less than 1-2%. But there's something also that I would like to highlight about these grade 1-2 toxicities that are usually not given the importance. Of course, you have to use supportive measures for antiemetics, prokinetics, exercise programs for fatigue, as Giorgio said in the previous talk. But if we go to the CTCAE, a grade 2 nausea is that you are 24 hours of a day with nausea, that decrease oral intake without weight loss, but being all day every day with nausea, I mean, it may not be serious, but it's sure bothering. Fatigue is the same. I mean, a grade 2 fatigue, this is a definition of grade 2 fatigue, is fatigue not relieved by rest. I mean, you try to rest, you sleep, you sit in your couch for a couple of hours, and then you wake up and you're still as tired as before. So, and it limits instrumental activities of daily life. And once again, decreased appetite is that you need oral nutritional supplements. So once again, when we see, well, it's a grade 2 toxicity, it's not so relevant. It is relevant, and it should be also treated with supportive measures as the best way we can. So, and just as a final comment, I mean, of course, I'm a medical oncologist. I'm biased. I love chemo, but of course, I love some other systemic therapies. But when we say that one drug or one class of drugs is more toxic than the other, I mean, I would prefer to hear that they have different toxicity profiles. We have a phase 3 trial, which is the Triton trial, that compares directly rucaparib, which is a PARP inhibitor, versus docetaxel in mCRPC patients. And we see that when we compare face-to-face a PARP inhibitor with chemo, with docetaxel, for nausea, anemia, decreased appetite, vomiting, renal failure, thrombopenia, the rate of adverse events is higher with a PARP inhibitor. Of course, other toxicities associated with chemo, neuropathy, mucositis, alopecia, febrile neutropenia are much higher with chemotherapy. But we shouldn't say that one drug is less toxic than the other. One drug has a different toxicity profile, or what to expect from one drug is different from what to expect from another. And if we group all the toxicities, rucaparib had more interruptions of the treatment due to an adverse event, more dose reductions, and more death from adverse events, the 2%. Docetaxel had more permanent discontinuations due to adverse events. But once again, I mean, this is just an example, but this is the only comparison inside of a phase 3 clinical trial between these two classes of drugs. So you have to know well the toxicity profile of the drugs to use them well, not to say, I choose this drug because it's less toxic than the other. I mean, I don't agree with that point of view, but of course, we may discuss it in a couple of minutes. So to conclude, once again, the old-fashioned triplet, we speak about triplets in MHCPC, but we have a triplet, which is patient treatment tumor, to choose a treatment in a particular setting of, in this case, metastatic prostate cancer. The patient and caregiver information of side effects is key. For chemo mainly, but also for PARP inhibitors, dose and schedule adjustments are safe. You are not losing efficacy and are feasible. So try to individualize in every patient as toxicity appears throughout the course of the treatment. The proactive toxicity management is important, mostly for anemia, neutropenia, nausea, diarrhea. Don't let a grade 1-2 toxicity progress to a grade 3-4 toxicity. For these treatments and for every systemic treatment, in my opinion, you should ensure availability and accessibility if the patient has to come back earlier than expected for these serious or unexpected toxicities. And for this, as the title of the whole webinar says, I think that multidisciplinary care in every tumor, in every malignancy, but in prostate cancer also is a must and should be used in everyday practice. And thank you for your attention.
Thank you, Alvaro. Thank you very much. It was a great talk. And we actually have some questions using the chat. And the first one connects with what you were discussing. And is, do you run a joint oncology clinic with metabolic specialists to provide the BMD enhancing agents in those at risk? And actually, my answer is yes. We recently started it at our place, and I was surprised by the collaborative mood we actually had from our colleagues. So it's something they see, they are used to, and they are very supportive. I don't know if you have the same experience at your center, Alvaro.
Yeah, I am happy to hear that, because I think that more and more people are more convinced that getting everyone together to share the best of their knowledge for the patient is important. We both have a rheumatology dedicated for this kind of bone health, osteoporosis, and so on, and also a cardio-oncology colleague that does an excellent job for patients, for assessing patients with cardiovascular risk before initiating hormone therapies, and to see also the evolution of cardiac function. So, I mean, I think that, I mean, of course, not every center has the same possibilities, and one should adapt to everyday reality, but at least I think that we should in our own possibilities, try to push for this to optimize treatment for these patients.
So we have other questions related to what is the indication for chemotherapy in these patients?
Yeah, I mean, as I said before, in this kind of patient flow and stages and patient journey, I mean, chemotherapy is included in different stages. As you all know, it's approved in metastatic hormone-sensitive prostate cancer in the form of a triplet with ADT and both abi or darolutamide, but also the first indication was in metastatic castration-resistant prostate cancer, either before or after a novel hormone therapy. I think that once again, there's no formal indication. I mean, you have to evaluate a patient, what has received before, what was the response to previous therapies, what has been the evolution and toxicity to previous therapies, and just to know that chemo is one more option. I don't think that chemo is a standard option for patients with this and this. I think that chemo is one option to consider in the whole bunch of options that luckily we have. We had not so long ago, we didn't have any option for systemic therapy. Like 15, 20 years ago, there was nothing that we could offer to our patients. Now we have a lot of treatments to offer, and there's no optimal sequence of treatment for every patient. I think that we cannot say that. So that would be my answer, that there's no definite answer. You have to individualize any patient. Just to have it there, like you have the radiopharmaceuticals, like you have the novel hormone therapies, like you have PARP inhibitors, like you have clinical trials, and every patient is absolutely different from the next one.
And what about obstructive nephropathy? Do you see patients with this condition, and how do you deal with them?
Yeah, I mean, it depends also. I mean, if of course, every patient, as I'm sure most of you also in your institutions are discussing the multidisciplinary tumor board, and for patients that have a long life expectancy, and we feel like optimizing renal function is key to administer any given therapy, any efficacious therapy, either approved or clinical trial. I think that it's time to sit and discuss with the patient and tell them the truth. I mean, if we don't solve this mechanic complication, if you wish. I mean, I'm not a urologist, of course, and I'm not going too deeply into the details, but if you don't solve this, there are some options that are out of the table. So if you have an acute complication that can be solved in a patient with long life expectancy, I think that it should try to be solved if the patient agrees with that. But I don't think it's, I don't think it's a terminal event, right? So if a patient has this, okay, forget about everything and see you. So I think that is an acute complication that can be resolved, and it's worthy to be resolved in a lot of patients.
Yeah, I agree. And the issue is that these patients are typically patients with a high disease burden, so they are difficult cases to deal with. Okay, with this, I think I don't see any other questions, and we use the chat to answer all questions. So thank you again, Alvaro. It was a very productive and interesting meeting, and thank you very much.
Thank you. Thank you so much for the invitation. It was really a very, very good experience. And once again, thank you.
Have a good evening and goodbye.
Bye.